So for our final talk for this session, I'd like to introduce Professor Stephen Attwood, who, as Kuma alluded to earlier, the king of EOE, eosinophilic esophagitis, and he's an upper GI surgeon who first discovered EOE in 1980s. And I have learned a lot from him as a junior consultant. Stephen, if you could present the food bolus obstruction and eosinophilic esophagitis talk.
Thank you very much, Jing, for your kind introduction, and thank you for inviting me to speak here. It's a pleasure to be here. So I'm going to focus my talk on about EOE on presentation and management of food bolus obstruction in particular. I do have some conflicts of interest as I work with anybody who cares for patients with EOE. So the definition of EOE is a chronic disorder in which the eosinophils are infiltrating the esophageal epithelium and fibrosis develops in the submucosa, and it's characterized by symptoms of esophageal dysfunction. That's the official definition, but that's almost always dysphagia. And the dysphagia is present usually for a long time. Since its original description, EOE was regarded as a rare disease, but now it is relatively common with a prevalence of 86 per 100,000, and it is in fact the commonest diagnosis if you send somebody for endoscopy and biopsy for dysphagia. 25% of those patients are found to have EOE, so it is now a relatively common disease and becoming commoner. I just want to focus your attention on what the esophagus looks like, just to get some understanding about what happens in EOE. So the esophagus has got some simple layers of mucosa. In blue there, the white layer is the submucosa, which is a light and very expanding layer, and then the muscle on the outside that provides peristalsis. And in EOE, you get inflammation in the wall that's in the mucosa, possibly through food antigen reaction, but we're not sure. But the eosinophils and the mast cells and the fibroblasts, and you don't see those other two so well, lay down fibrosis in the submucosa, which I've highlighted here in yellow. And once you start to get that fibrosis, then it won't expand. And then food won't go through if it's solid, because it can't expand to allow the food to go through. So you don't need a stricture to get a food bolus obstruction. EOE occurs at any age. It's commoner in younger people, so between 15 and 45 is the commonest time of presentation. And it's commoner in white races, but not exclusively so. It's quite common in the Middle East. It's very common in odd places like Brazil, where they have huge numbers of cases. So it's throughout the world in mostly white races. Men are nearly 4 times more commonly affected than females. And interestingly, it's got a relationship to atopy, such as bronchial asthma, rhinitis, conjunctivitis. But the things that the patients might react to are often different in EOE to those they react to with their asthma. And when I first described it, I used the term asthma of the esophagus, which kind of helped explain to people what it was and is easier to say than eosinophilic esophagitis. I've been practicing that for many years, but it's hard to say when you say it for the first time in front of a patient. So the most common symptom of EOE, as I said, is solid food dysphagia. Chest pain is relatively rare, only 10% of our patients get it, but food impaction is the topic of today. Now, in younger children, those below the age of 5, they don't tend to have their parents come and say, my child has got a difficulty in swallowing solid food. They say the child is refusing food, or it's regurgitating because they can't swallow. The child probably does have dysphagia, but just can't describe it. And dysphagia to an EOE patient is usually something that's been there for many years, including those who present for the first time as a bolus obstruction. They've just become used to the fact that they're the slowest eaters at the table. They have lots of water to help them drink. They're aware the food is going down really slowly, and they have to chew and chew and chew before they swallow. So these are people who think that's just them, that that's not a disorder, that's just the way it is. But it's actually a form of dysphagia. And as soon as you recognize this circumstance, then a dysphagic patient requires referral for endoscopy. That's been a standard guideline for a long time at a GP level. So refer for endoscopy and biopsy all patients with dysphagia. And you'll discover many more EOE patients than you will cancer. And at endoscopy, dysphagia requires a biopsy, even if the endoscopy looks normal, and we take multiple biopsies. There are some endoscopic signs that are visible, but because the mucosa may look normal, we have a rule that you biopsy everybody who has dysphagia. So these are examples of what an EOE patient look like, and it's kind of interesting and peculiar that they're quite different from each other. So some patients have furrows, some patients have rings, some patients have white exudates where there's little abscesses of eosinophils. Some patients have a tear easily in their mucosa called crepe paper. A few have strictures, but not many have a visible stricture, even if the whole of the esophagus is narrow. So regardless of what it looks like, the patients need multiple biopsies. And we know if you take one, you miss half the cases, and if you take 6, you'll get almost all of them. So that's the way we define it. 6 biopsies taken from multiple levels, because it can be a patchy disorder around different parts of the esophagus. And the complications are stricture, which I've already mentioned, prolonged food bolus obstruction, and also, for your information, esophageal perforation. A spontaneous perforation in the esophagus. The commonest cause of that by far in our community is eosinophilic esophagitis. And it's not Boerhaave syndrome, that's a different kind of condition. I've put in a 4th complication here, which is the psychosocial complications of the dietary therapies. I'm not going to discuss diet much, but for reasons like the previous speakers were saying, the use of diets is rather difficult, and when enforced on young children can create more problems than the underlying disease itself. I just put this up briefly as a stricture just to sort of show you a typical story of the patients I see. This young man came to see me at the age of 17, and for the previous 10 years he'd never swallowed a solid meal. You can't get anything through that tight stricture. And he had that barium done actually when he was 12, 5 years after being started on a PPI by his paediatrician. And that stricture looks absolutely typical of EOE. So I knew immediately I saw this x-ray, I'd be able to fix this guy, and so we gave him a dilatation. Now this is a young man who developed well. He's no softy. He was a captain of his rugby team. He was a little guy, he was a scrum half, but tough and muscular. He'd brought himself up on protein drinks and milk shakes so that he could be big and strong. But he couldn't eat a hamburger and chips with his team until I gave him a dilatation and, of course, the steroids, and he was really happy. But it shouldn't take 10 years to get the diagnosis, particularly if you've got an x-ray like that. But many of our patients just turn up in A&E. A third of the patients who have EOE present their first symptom to the doctor as a food bolus obstruction in A&E. It's not the first time they've had a problem, but it's the first time they've presented with it. And generally speaking, they'll kind of come when they've got enough distress. They'll have managed for previous occasions on their own, but now maybe it's gone on for a couple of hours and they get anxious. They'll have attempted to wash it down with some fluids, and so they will come and seek attention in the A&E department. And it is now quite a common problem in A&E. So EOE is actually the commonest cause of food bolus obstruction. The literature says 50 to 80%, and it's probably close to 95% because not a single series in the literature takes a biopsy in 100%. We've got a real problem in persuading people to do the darn biopsies, but whenever they're taken, they're likely to be positive. And we know that 30% of our patients who have EOE come as a food bolus obstruction. The underlying prevalence of EOE is growing, I've said that earlier, and my own estimate is that about 25 people per 100,000 have a food bolus obstruction per annum. That's quite a lot. That translates into about 300 patients per annum per hospital trust. So it's a common GI emergency. In fact, it's now commoner than GI bleeding as a reason for emergency endoscopy. And this series from Australia just shows that it's been going up gradually over the years, and that study ends in 2010. But I was in Australia last week and they told me that it's double that now at 360 per annum in their hospital. So it's exactly the same frequency of food bolus and the same frequency of EOE. And interestingly, I was in Cardiff just yesterday and they did an audit of their food bolus obstructions, and they had 900 food bolus obstructions to their A&E in the last 3 years. It's a common problem. So be aware of it. At endoscopy, it's actually quite easy to remove the food bolus. We now use a big suction cap. It's like a sort of a big sucker thing that we put down on the end of the scope and just suck the whole lot up. It takes a couple of minutes in most cases, and so it's really easy. In this case, those of you who are gastroenterologists or endoscopists can see the furrowing. It's an obvious case of EOE, and once you've taken the thing out, you just get on and do the biopsies. So, for food bolus obstruction, an urgent referral to gastroenterology and a list for endoscopy is needed at the next endoscopy list. And so we have to educate our A&E and ENT colleagues to make sure that this happens. And by the way, we now have a BSG guideline that was accepted, I'm pleased to say, just yesterday for publication next month in Gut, and this is what the guideline will say. After the bolus has been safely removed, biopsy should be performed immediately at the index endoscopy. There is a tendency that people go, oh, well, I've taken the bolus out. They can come back and we'll do the biopsies another time. Young men, as these usually are, don't come back. This is your opportunity. And if you're in primary care and you've found out that they haven't had a biopsy, make sure they get sent back for endoscopy and biopsy. The therapy of a food bolus is removal of the bolus, instituting immediate anti-inflammatory therapy, and sometimes a dilatation if you see a stricture. So they should have had some immediate therapy if there's an opportunity, and if there's the right number of biopsies are taken, it's appropriate to start them on the anti-inflammatory treatment. And that should not be proton pump inhibitor. Some guidelines say start PPI in the belief that reflux causes bolus obstruction. Reflux does not cause bolus obstruction. I can say that in black and white. It's EOE, and EOE is not related to reflux disease. PPIs are a little confusing because they have some effect on the pathway of eotaxin 3. They have a reduction in the eosinophil count in the esophagus and a partial improvement in symptoms in EOE, which actually is a confusing scenario. It rarely cures the problem. And if you start a patient with a PPI, it might dampen the eosinophils, and if you've not taken the biopsies, you can't get the diagnosis. So don't start a PPI. And make sure the patients are not discharged. They should have an outpatient appointment, so if they see you as a GP, they should have had an outpatient appointment to discuss the biopsy findings and an explanation of what EOE is and what the treatment is and how it should be run, and it's a chronic disease, so they will need maintenance therapy. It's no good just giving them a short course and stopping. It will come back, as I'll show you later. I briefly just want to go through the therapy of EOE in relation to food bolus. Traditionally, we say there's diet, drugs, and dilatation therapy for EOE, but the drugs and the diet generally only treat the inflammatory component, and diet is no good for treating the fibrotic component. Likewise, PPIs are no good for treating fibrosis. So in a patient with a food bolus obstruction, the first line therapy should be a dedicated topical steroid, and I'm going to give you a little bit of detail about that. Steroids address not just the eosinophils, but the mast cells and the fibrotic cells. They should definitely not be on a systemic steroid, because you can't get the systemic steroid to the lining of the esophagus in such concentration, and of course there's adverse side effects. Well, until very recently, we had to use adapted asthma products. We were using inhalers that were getting patients to swallow budesonide slurries, and they just all end up in the wrong place, and they don't work so well. They work very partially, but not well. But now we have an orodispersible form of budesonide called Jorvesa, which is a potent glucocorticoid that's highly effective in this condition. It's the only licensed therapy for EOE, and NICE have approved it, and now the BSG guidelines recommend it for this circumstance. The instructions to take it are really easy. It's a very simple tablet. Put on the tongue. You don't put anything else in. You don't drink it. You don't chew it. You don't swallow it. It just dissolves in saliva. And the idea is there's a very small volume of fluid that will carry it to the surface of the esophagus, and it'll all stick, which it does very nicely. Briefly, I just want to show you the pivotal study that proved it worked in terms of inducing remission. There's only 88 patients in this study, tiny study, because it was so easy to get statistical difference. And in this particular study, we had a 2-to-1 randomization in favor of the drug, as the young men wanted to know they'd get some active treatment twice as likely as the placebo. And in this study, they'd all failed a PPI. You don't have to have failed a PPI, but in this study, they had done. And they were typical of the young guys. They were about 8 years since their diagnosis. 80% of them were male. They had a typical age around the 30s, and they'd often tried other therapies unsuccessfully beforehand. And the results at 6 weeks, which were as long as we were allowed to do the placebo phase for ethically, it's not as long as it takes to treat the EOE, but at 6 weeks, no patient on placebo had resolution of their eosinophils, whereas 92 to 95% of the patients had complete resolution of eosinophilia in the esophagus, whether it's the proximal, mid, or distal. And even though the symptoms took a while to go away, they started to go away immediately. So within 2 weeks, there was the difference between the placebo and the treated groups. At 6 weeks, 5 days a week, the patients had no dysphagia. Bearing in mind, these guys had dysphagia every day at the start. And then at 12 weeks, because we extended it for 12 weeks, they were dysphagia-free for 7 days. And endoscopically, the signs of EOE disappeared at 6 weeks. So on the left is the placebo. Moderate and severe is the blue and the purple. Purple and the red, and it's the same baseline at 6 weeks, whereas active treated patients, the blue and the red, disappear more or less completely at 6 weeks. And although only 57% of the Gervaisa patients had no symptoms at 6 weeks, by the time we got to 12 weeks, it was almost 85% of the patients. And there's rarely a drug that resolves a chronic problem in such a high percentage of patients in inducing remission. So this is a remarkable slide in that context. But of course, some people say, well, that's just a randomized trial. Things are always better in a randomized trial than they are in real life. So we've done a few open label studies, and I'm very pleased to say that in open label studies in primary care practices, we've identified that remission histologically is still 90%, and clinical remission is at 75% at 6 weeks. In other words, it's a lot better. The reason it's better is that we were able to choose people more broadly, and not just those who'd failed a PPI, but if you take the broad range, then they all will improve more quickly. And just to highlight that, you get a lot of symptom improvement, but without complete symptom resolution. And it's really important the guys don't know what normal is. They've not swallowed normally for ages and ages. So some of them will say, oh yeah, I'm getting better, but they don't know quite where better is. So 75% of them were measured as being completely able to swallow all solids, whereas 85% of them thought they were doing fine, but not quite normal. But of course, this is a condition that's chronic and you need maintenance therapy. So we've done studies of budesonide, oral dispersible, 1 milligram and half a milligram over a period of a year compared to placebo, starting out with patients who'd all got complete remission. So these now were patients who had received their budesonide, had no dysphagia for 7 days a week, and entered this study. And at the end of a year, 75% of them on Gervaisa were completely well with no histological recurrence and no symptoms, whereas only 4% of those on placebo were still well in the same definition. So that shows you that the condition will come back if you don't treat it, but it'll stay away if you do. And the intention to treat population had some significant persistence of the condition, but the per protocol patients were a lot better off, because if you took your medication for the full year, you had a much better chance of not having EoE than if you'd forgotten to take your medication. And that's what this slide shows us, that the guys who were suffering some eosinophilic relapse at the end of the year, 10% of them had some eosinophils, and that was the number that failed to comply with their daily medication. And the condition clinically relapsed in 7 to 10% of those on the Gervaisa. Again, those are the ones who failed to comply with their daily therapy, but had clinically relapsed in 60% of those patients who were on placebo. And interestingly enough, although the patients all thought they were perfectly well at the beginning of the study, those on Gervaisa continued to get better during the year. There was a 9% increase in their quality of life scores in the 1 milligram dose, slightly less in the half milligram dose. But those on placebo just got worse. And again, we have an open label study now over 2 years of maintenance that's highlighted this. And it's really interesting. And the longer it goes on, the higher the figures get. So we now have 82% of patients who are in complete clinical remission at 96 weeks. So that's up from 75% at the end of a year. If these guys can continue taking their medication, they go on getting better the longer they take it. And the reason for that is that the longer you take your steroid, the more likely your underlying fibrosis is to resolve. Now, interestingly enough, some people are not sure, should everybody go on maintenance or not? Well, this slide, I think, gives the answer that if you choose to just give a 12-week induction course and then stop, half the patients will have remission at the end, will have recurrence at the end of just 3 months. So see the patients at 3 months and make sure they have endoscopy and biopsy, because half of them will have recurrent disease. They may not have detected it clinically yet, but they need to be on long-term maintenance therapy. Now, side effects are important to know about. About 5% patients per annum will develop oropharyngeal thrush, which does need treatment with nystatin suspension. Really easy to do, it's not a problem, but you mustn't stop the topical steroid. And in all of our clinical studies, it was easily treated, so they don't need systemic antifungals. No systemic side effects have been seen, and we've got lots of data. The one thing I should say is that we've not published the data on children yet. We don't have a license for children. So although it will come in the future, you need to be aware of that at the moment. And the reason it doesn't have side effects is that it's got a 90% first pass metabolism in the liver. So with one circulation, you've got rid of 90%. And on the second circulation, you've 90% of the remaining 10% gone. So it just disappears really quickly. You don't get systemic side effects. And it has nice approval. It's the only licensed drug, and as I said, now we've got guidelines from the BSG, which you will be able to see published next month, which is just great. So in summary, ladies and gentlemen, EOE is a chronic disease that's increasing in frequency. It causes a reduction in quality of life across the board for these patients in relation to eating problems. You need to refer all your patients with dysphagia for a gastroscopy and a biopsy. If they've got EOE, you need to be aware of the complications of stricture, bolus, obstruction and perforation. And the mainstay of therapy in any patient who has fibrosis is the orodispersible preparation of budesonide. Thank you very much.